خل اشوف هذا اول شيء شو ماكو
شنو يكتب؟ جواها لا لانه موز ثاني كذا
هذا هيك
الكتابة انت زي تطلع واضحة
اي اوكي اتس كلير اوكي يعني نبدي بسم الله الرحمن الرحيم. My name Dr. Mahmoud Al-Kindi. I'm a gastroenterologist here in the University of K.U.C.O.M Faculty of Medicine. Today I would like to share with you some information about inflammatory bowel disease. So inflammatory bowel disease, as you know, is one of the famous GI conditions that affect the bowel. So what is the definition of inflammatory bowel disease? As you know, inflammatory bowel disease comprised two conditions characterized by chronic or relapsing immune activations and inflammation of the GI tract. We have three main types and classically two main types: Crohn's disease, which may involve any part of GI tract from mouth to anus, but with more towards the distal small intestine, which is called terminal ileum, and proximal large bowel. This is called the Crohn's disease. Ulcerative colitis, it means diffuse mucosal inflammation limited to the colon. While if there is no specific characterization to either of these two conditions, so we call IBD unclassified or indeterminate inflammatory bowel disease. So 5 to 15% of patients with inflammatory bowel disease, they don't have either these conditions. So they have mixed pattern, which doesn't allow us to categorize the condition either Crohn's or ulcerative colitis. So what about the pathophysiology? So many patients ask us, why I am getting inflammatory bowel disease from others? So the most acceptable theories about the inflammatory bowel disease is that there is in certain genetically susceptible individual, there is abnormal inflammatory response to environmental trigger, and no one knows that what is the inflammatory trigger. Some they say it is virus, some say this is bacteria, and this will inflammatory triggers that it lead to the activation of innate and adaptive immune response, and these to the release of the inflammatory mediators, which is called like tumor necrotic factor alpha, interleukin 12 or interleukin 13, which are the main target for our medications. There is no association between microbial dysbiosis. There is recent theories. They stress on the correlation between microbial dysbiosis and inflammatory bowel disease, and they seen that when they took a culture from the stool of patients with inflammatory bowel disease, they seen that there is a reduced diversity of commensal bacteria on the expense of the harmful bacteria. Functional changes in the bacteria can happen and lead to the reduction in anti-inflammatory mediators, like for example butyrate and other short chain fatty acid. These are all the notice that have been noticed by the scientists regarding the causes and the pathophysiology of the inflammatory bowel disease. And there is emerging evidence about the virome and microbiome. The fungal species may be important in development of inflammatory bowel disease. So this is the main theories that I link to you in this slide, the main ideas behind the pathophysiology of inflammatory bowel disease. Okay, what is the incidence of the inflammatory bowel disease? So it varies between the different populations. For example, in Western countries, there was dramatic increase in incidence of both ulcerative colitis and Crohn's disease. And usually the inflammatory bowel disease, they seen that there is a recent increase in incidence in last century. And some theories behind this because of introduction of more hygienic environment and discovery of the domestic refrigerations as linked to the previous centuries without refrigerators, without a fridge, and the wide use of antibiotic. This made the theories behind the recent increase in the inflammatory bowel disease in the last century. Because of the the developing country adopt more westernized food, so there is also an increase in the incidence of inflammatory bowel disease. In West, the incidence of ulcerative colitis remains stable, about 10 to 20 cases per 100,000 person, with a prevalence of 100 to 20 person per 100,000, while the incidence of Crohn's disease increasing in the recent years is now about 5 to 10%, with a prevalence about 50 to 100%. So both diseases occur most commonly in second and third decade. So young age group is the peak incidence of age about those occurrence of inflammatory bowel disease. And there is late incidence peak in the elderly age group in the seventh decade. Now we have certain comparison between the two categories. The ulcerative colitis, as I said, we have two main categories of inflammatory bowel disease: ulcerative colitis and Crohn's disease. So regarding the age, so any age can be targeted, and as I said, the young age group is the main target of the or incidence of inflammatory bowel disease. In ulcerative colitis, usually the male equal to female. The incidence of this disease happen in both the male and female, while in Crohn's disease there is more happening in female regarding the male on the expense of the male. The incidence of the ulcerative colitis, as I said in the previous slide, is the stable regarding ulcerative colitis, while it is increasing nowadays regarding Crohn's. There is genetic factors in the both. So HeLa DR103 is more prevalent in ulcerative colitis, while there is defective innate immunity and autography not 2, and is the main like genetic defect in the Crohn's disease. Risk factor, all, and after you see many patients in the next few years, so you will see that the ulcerative colitis more in non-smoker or ex-smoker, and people they have appendectomy, most of them they don't get ulcerative colitis. And this is also the association. So many studies showed that patients having appendectomy they have less prevalence or less incidence of the ulcerative colitis, while vice versa in Crohn's disease can happening more in smoker people, and the incidence of appendectomy more common in Crohn's disease. Regarding the anatomical distributions, in ulcerative colitis, colon is the main target of the main site, and the most common site of the involvement is the rectum. So anorectum is the most common involvement and more starting of the disease, and as the disease progresses, so it can involve the proximal part of colon. While in the Crohn's can involve any part of the GI tract from the mouth to the anus, and it can involve some patient they have perianal disease, some they present with the fistulizing disease, and etc. And the Crohn's characterized by skip lesion and patchy distribution, while the ulcerative colitis usually they have continuous inflammation. If you see the colonoscopy report of the patient with Crohn's disease or ulcerative colitis, so ulcerative colitis characterized by continuous inflammation without intervening normal mucosa, while the Crohn's disease they usually have the skip pattern. Both of them they have extraintestinal manifestation by joint, skins, and etc. Usually presentation of patient with ulcerative colitis is bloody diarrhea, and usually I ask my students about what are the main triad of patient with ulcerative colitis. So rectal bleeding, abdominal pain, and urgency. So rectal bleeding usually associated with the in form of bloody diarrhea, while the main triad of patients with the Crohn's disease is the watery diarrhea, weight loss, and abdominal cramps, because usually the inflammation causes stenosis to the bowel, and usually the patient presented with the bout of colics. Histology, when you see the biopsy report of patients with ulcerative colitis, inflammation is limited only for mucosae, like characterized by crypt distortions, cryptitis, crypt abscess, and loss of goblet cell, while the inflammations of the Crohn's disease usually transmural and characterized by deep fissuring and the fistulae and patchy change and associated with granuloma, which is mainly pathognomonic for the presence of the Crohn's disease. So regarding the management, so the main management is they share both management, but one point that I need to link here, colectomy is a curative. When you remove the colon, so there is a complete cure of the ulcerative colitis. And the main treatment of patients we start with usually with 5-ASA, while in Crohn's disease, the 5-ASA no more be effective. Unfortunately, still there is many doctors prescribe 5-ASA for Crohn's disease, but as I said, recent study showed that there is no any evidence for effectivity of 5-ASA in patients with the Crohn's disease. This is a very important slide. So we jump to the another slide. As you can see, as I mentioned, ulcerative colitis characterized by the continuous inflammation and involvement of the colon, while if you see the Crohn's disease characterized by skip pattern, so it can start also in colon, as I said, from the mouth to the anus, but it characterized by skip pattern. So you can see there's a piece of inflammation here, while the intervening colon or small bowel will be normal. So this is the main difference of Crohn's disease and the ulcerative colitis. Also, the Crohn's disease characterized by transmural inflammation. So as you can see, this is the layers of the colon or the bowel. So from the serosa to the mucosa in the Crohn's disease can be involved. While the ulcerative colitis, only involvement of the mucosae, so no penetrating disease. So therefore, because of the penetrating disease, the patient with the Crohn's disease can be present with the fistulae, strictures, and abscess pad. Here, like the slide of patients with the Crohn's disease, as you can see, there is a presence of granuloma, which is the characteristic of and pathognomonic for Crohn's disease. Granuloma, non-caseating granuloma, while caseating granuloma can happening also in TB patients. Cryptitis and crypt abscess can happening in patients with ulcerative colitis, which is the characteristic of ulcerative colitis. We come to the clinical feature. So what are the main clinical feature of patients with ulcerative colitis and inflammatory bowel disease? So stool frequency and consistency, urgency, nocturnal diarrhea, tenesmus, rectal bleeding, abdominal pain, vomiting, fistula, perianal disease. All these symptoms are common in patients with ulcerative colitis and the inflammatory bowel disease, like whether ulcerative colitis or Crohn. But keep in mind, there are certain symptoms that can happen even in IBS, or what is called irritable bowel syndrome. So, but the presence of blood, the presence of the nocturnal diarrhea, it can help you think that this is a cause, or this is a condition of organic conditions, and the main condition might be the inflammatory bowel disease. But IBS, or irritable bowel syndrome, as you know, there is never ever patient having like such symptom. Usually IBD having, especially if it is active disease, they have extra-intestinal manifestation in form of joint, skin, mouth involvement, and eye. So mouth ulcer, after ulcer, many patients presented with the after ulcer to us, and when we examined the bowel, we found the patient having Crohn's disease. So when you took a history from the patients, so especially, usually you need to ask the patient about the previous symptoms in the past, because this may give you a hint that the patient having like a previous or chronic illness, because inflammatory bowel disease is a chronic disease, a chronic inflammatory condition, so it can involve the having relapsing and remitting like episode. So when you talk to the patient with inflammatory bowel disease, they told you that they have many missing days. They miss the social activity because they have urgency and abdominal cramps, preventing them from going to the works or to the school or to the college or the faculty and to the social event. So they give you the same. But patient, if you took a history from other patient like IBS, they usually adopt with their or cope with their symptoms. But patient with inflammatory bowel disease, they told you I couldn't attend social activity because of the urgency that I have or because of the significant abdominal colic that I have, which prevent me from the attendance of the many social activity or my usual life. Mood disorder can be happening because of the chronicity of disease. Many patients, they have depressions and anxiety because of inflammatory bowel disease. So regarding the time course, many patients ask you, what will happen to me if I got inflammatory bowel disease? So what you want to tell him is that, or tell her, is that the patient, they have either relapsing remitting condition, usually they have like in form of the care. This is a relapsing care, days of remission, days of activity. Or some they have a progressive disease. So cumulatively the inflammation will increase and then it will end with the like disaster situation with the like structuring in the inflammatory Crohn's disease, or might be like the very severe colitis and ulcerative colitis. Or the patient have intermittent intermittent inflammations, comes and goes. So you need to ask about the previous appendicectomy. As I said, appendicectomy can prevent having of ulcerative colitis because it is less associated with ulcerative colitis. But a patient with having previous appendicectomy, they thought that they have more common or more incidence of Crohn's disease. Recent infection, you need to ask about travel history in order to differentiate whether this is infectious colitis from the inflammatory bowel disease. Contact with the enteric infectious illness with patient having food poisoning is also important to discriminate whether this is truly inflammatory bowel disease or it is infectious colitis. You need to ask about vaccination history because patients with inflammatory bowel disease, they need to take certain vaccine in order to prevent the flare-up because many patients require the immune modulator, immune suppressive medications, and this is allow the viruses and to happen to them if they are immune compromised, like hepatitis B or hep C. So we need to take the vaccine against those microorganisms to prevent getting viruses when they are on the immune compromised medications. So you need to ask the patient whether they got TB or non-TB because the presentation of TB colitis similar to the inflammatory bowel disease, and even if the patient getting inflammatory bowel disease and they got previous TB, when we put them on the immune modulators or immune suppressants medication, there is a flare-up. So one of the points that we do usually, we search for TB by X-ray or by blood test in order to prevent the flare-up of TB when we put the patient on biological treatment or immune modulator. So you need to ask about whether the patient they took antibiotic or NSAID in order to know these symptoms might be caused by side effects of these medications. Family history is important because many diseases associated with inflammatory bowel disease and many it is a genetic disease, so it can happen in brothers and sisters or the second degree relative. So you need to ask about inflammatory bowel disease history in families, member, and also whether the patient got celiac disease or history of cancer. Cigarette smoking is very important, sexual history and food intolerance. So there is some definition you need to know about each disease. So for example, if you ask whether the patient have active disease, so you need to know whether the patient having active disease or no. So when we say this is active disease, mean the patient having like activity of disease. They have like symptoms, and usually we score the ulcerative colitis according to the Mayo score, whether they have mild, moderate, or severe disease. While Crohn's disease, usually we have what is called CDAI score, and we give a mark. I will show you in the next few slides what is the CDAI score, and we categorize the patient whether mild, moderate, severe. Remission, it means that complete resolution of the symptoms, and there is endoscopic mucosal healing. So when the patient having remissions, so we have like complete disappearance of this symptom, which is called clinical remission, and we have biochemical remission when there is normalization of inflammatory markers, and also we have like what is called radiological remission, endoscopic remission, and the histological remission. So it means that disappearance of symptoms and normalizations of biochemical markers and the endoscopy and the biopsy. And even in Crohn's disease, we need to normalization of the like MRE in order to know that the complete bowel, it will be healed by medication. The another thing that the remission in Crohn's disease, when we call the CDAI score less than 150. Relapse is the flare-up symptom. The patient was in remission, and all of a sudden there is symptoms develop, and this is happening whether the patient stop medication or happening spontaneously. There is some definition include rectal bleeding as essential component of the relapse in ulcerative colitis. And other include combination of rectal bleeding or increase in stool frequency and abnormal mucosae in order to define there is active disease or a flare-up of disease. There is other symptom, as you know, many patients with Crohn's disease, they went to the surgeon and they resect the bowel because of the intestinal obstruction resulting from the stricture of the bowel. And after the patient's diagnosed with Crohn's disease and after surgery, there is recurrence of symptoms. This is mean that reappearance of the lesion after surgical resections. Okay, this is the, this is this. Okay, so I need to, this is slide. Okay, so this is a Mayo score. If you see, this is usually I write the Mayo score for my patient in order to know whether they have active disease or they are in remission. So we give a score for stool frequency per day. We give a score for rectal bleedings per each bowel motion. We give a score for global assessment, and we give a score for endoscopic finding. And we categorize the patient whether they have mild, moderate, severe disease according to the Mayo score. This is what is called Mayo score. And this is the CDAI. So there is certain symptom. It depends on the also the stool frequency, on presence of abdominal pain, general well-being, and also the intestinal symptoms. So for each of this, we give a certain score, and we categorize the patient whether they have active or disease remission. There is Montreal classification. When you comes to work with us in the GI center, so we'll see that we use the Montreal classification according to the age, locations, behavior. So we give each of these certain categories. This is regarding Crohn's disease. So also we classify the ulcerative colitis according to the extent and severity. So regarding the like ulcerative colitis, we categorize according to the extent whether they have proctitis, proctosigmoiditis, and as you can see, when the left colon, there is distal colitis or left side colitis, and the extensive colitis when the involvement like 2/3 of the colon, and pancolitis when there is involvement the whole colon. What about the physical examination? So when you encounter any patient with the inflammatory bowel disease, so you need to measure the weight, calculate the body mass index, you look to the pulse rate, blood pressure, all the vital signs. in order, especially when the patient have active disease. And you need to examine the bowel to see whether the patient got any tenderness, distension, or whether they got certain mass. And you need to also look for the perianal lesion and do the digital rectal exam to see whether the patient have any like tags or fissure, fistulae, abscess, especially in patients with the Crohn's disease. And there is extraintestinal manifestation. You need to look for the general examination to see whether the patient they got any feature of extraintestinal manifestation. Okay. So what about the laboratory test? We do certain laboratory tests in order to like confirm the diagnosis and to assess the like the severity. We start with a simple investigation like full blood count, and full blood count help you to see the hemoglobin, to see whether the patient got anemia, which is one of the signs of chronic disease, or sometimes of iron deficiency anemia in case of the like strong bleedings or heavy bleeding can cause iron deficiency anemia. And in patients with Crohn's disease with involvement of the bowel, so it can lead to the malabsorptions. So MCV will help you to assess whether the patient have low MCV, which is mean microcytic anemia, which goes with the iron deficiency, or normal MCV, which can cause like anemia of chronic disease, which means the patient having like prolonged inflammations. High MCV might suggest B12 or folate deficiency, which can happen in patients taking immune modulator like MTX or thiopurine. So also the raised white BC count and elevated platelet count is one of the inflammatory markers, which can give you a hint whether the patient have evidence of inflammation, and especially if they got like concomitant microorganism like infectious colitis. Other blood investigation, we usually send for inflammatory markers, like when you see low albumin, it means the patient has strong inflammation or malnutrition. Elevated blood urea and serum creatinine, it happening with the active disease when they got evidence of dehydration. Electrolyte disturbance, it related to poor diets and long-standing diarrhea, so it can cause low magnesium, selenium, and the potassium. So iron study is very important in patients with inflammatory bowel disease, because low ferritin, it means iron deficiency. And when sometimes we got like normal ferritins and the or high ferritin, because as you know, ferritin is one of the inflammatory markers, so we need to do this transferrin saturation. So in patient with normal ferritin, so we need to send the patient for transferrin saturation, which means that the patient's having low iron, and you need to transfuse the iron or give iron supplement in patients with inflammatory bowel disease. So as I said, elevated serum ferritin is one of the inflammatory markers, and so you need to keep in mind that normal ferritin doesn't mean that the patient's having normal iron store. So you need to send the patient for transferrin saturation in order to rule out the presence of iron deficiency in case of the inflammations. Still, we need to consider the inflammatory markers. On the top of that is the CRP and the C-reactive ESR. But keep in mind, this can be helpful in suspecting inflammatory activity, but it correlates poorly with the intestinal inflammations and disease activity. So they are helpful if elevated, but normal value doesn't exclude the presence of even significant inflammations. So normal CRP and ESR, it doesn't mean that the patient doesn't have inflammation, but when they got higher CRP and ESR, it means the patient having active disease, and so you need to consider that normal ESR and CRP doesn't mean the patient having like clinical or biochemical remissions. So other serological tests which are rarely used nowadays is the ASCA for Crohn's disease and ANCA for the ulcerative colitis. They are not recommended for initial testing, can help to discriminate Crohn's disease and ulcerative colitis. As I said, it is rarely used nowadays because we depend on the clinical features and depend on endoscopy finding and histology histology, sorry, in order to categorize whether this patient having Crohn's or ulcerative colitis. One of the important inflammatory markers which are recently used by the gastroenterologist to know whether the patient's having like active disease or no is what is called fecal caloritectin. This is a very important recent biomarkers we use. It is secreted from neutrophil, and it is highly sensitive, non-invasive markers for intestinal inflammation, and can usually we send this biochemical markers in order to categorize this patient having IBS and IBD, especially in patient refusing to do endoscopy. And also another benefit of the fecal caloritectin is to monitoring the disease activity, whether the patient have current disease activity or risk of relapse or response to the current treatment or the dose. So we usually we usually depend on the fecal caloritectin for monitoring of the response for treatment, for detecting relapse in patient having like some patient, because patient with inflammatory bowel disease usually they comes for you, doctors, I have like certain frequency of the bowel, and you don't know whether this patient having associated irritable bowel syndromes or they have like truly an active disease. So this at this point, so you need to send the patient for inflammatory markers to know whether this patient having like truly active disease or IBS symptoms. The same thing's happening with patient having hemorrhoid or inflammatory bowel disease. Many patients come to us in the clinic. They said, doctors, they have complete remission in the disease, and they said, I have some drops of blood, and they're scared from this blood. In order to know whether the patient having active disease or not, so you need to send for the patient for inflammatory markers, and on the top of that is a fecal caloritectin, because many patients they got associated hemorrhoid, and this is drop of water of blood from hemorrhoid. It is not an active disease. So fecal caloritectin help you and aid you in order to categorize this patient whether having active disease or not. But keep in mind, there is false positive also with fecal caloritectin. So and especially in patient, and can be raised in patient with infectious colitis. So you need to link all the categories of the patient. You need to all the features, clinical features, other inflammatory markers, endoscopic findings, in order to give the right answer for the patient whether they have the active disease or not. Okay, so other stool examination can be warranted, especially if the patient have associated like food poisoning, or especially at the initial presentation of the patient. So you can send the patient for general stool exam or to the cultures. And also you need to send the patients for C. diff toxin in order to rule out the Clostridia difficile infection, and especially when the patient having a risk factor for C. diff toxin. As you know, there's certain risk factor, whether recent antibiotic use, elderly patient, and immunocompromised patient, or recent hospitalization. Other tests that you need to send the patient for inflammatory bowel disease is the endoscopy and colonoscopy, radiology. And this is will help you to establish the diagnosis and to assess the severity of the disease. So the colonoscopy is the main target for patient with for patient with inflammatory bowel disease. This will lead to the confirmation of diagnosis, and you need to look for the presence of the inflammations, whether ulcers, bleedings, erythema, stenosis, and you need to take the biopsy. Gastroscopy you need to be done in patient having like some sort of symptom of upper GI symptom like nausea, vomiting, and epigastric pain. Capsule endoscopy, sometimes we need to send the patient for capsule endoscopy to assess the presence and the extent of severity of small bowel. As you know, the Crohn's disease can involve any part of the, especially the small bowel, any part of the GI tract. So as you know, the endoscopy can goes to for the upper endoscopy can goes to the duodenum, while the colonoscopy can cause the distal part of the bowel. And there is the remaining part, the middle bowel, will not be reached by the usual endoscopy. That is why we need to do what is called K.U.C.O.M or the capsule endoscopy. But with the adventure of the MRE or MRE angiography, we do not use anymore the capsule endoscopy. And there is certain hazard with the use of the capsule endoscopy. As you know, Crohn's disease can cause strictures, and the capsule can be stick in this stricture, and we need to do what is called bowel resection in order to remove the capsule. So we have a question mark on the use of the capsule so in patients with the Crohn's disease. So, but sometimes we request that to confirm the diagnosis of Crohn's disease, but should be very cautious after exclusion of the structure or narrowing of the bowel. Imaging. So imaging, you need to be also cautious about sending the patient for imaging, because as you know, the main peak of incidence of Crohn's disease or ulcerative colitis is the young age group, and the radiation associated with CT, you need to be cautious about those patients because there is a risk of the cancer with the multiple use of the imaging or the radiations. So keep in mind, MRE is the magnetic resonance imaging. They don't need any like radiation, so it is more safer to be used in those patients. Plain X-ray can be established the diagnosis in patient with the extensive colitis and to exclude toxic megacolon in patients with severe colitis, and may give you an impression about the presence of mass or in a right iliac fossa in patient with the like Crohn's disease with feature of a small bowel obstruction. Barium, sometimes we send the patient with barium, but no more with the adventure, as I said, of the CT and MRI, no more we use the barium like barium enema. But as you know, the limitations of the of the MRE here in our society, sometimes we send the patient, still we send the patient for barium enema or barium small bowel. As I said, the cross-sectional CT and MRE can be used to determine the disease extent and severity and to assess the presence of perforating complication, especially in patients with Crohn's disease. And the recent adventure of the sophisticated operator on ultrasound can assess the patient with the required to repeat the imaging by doing ultrasound and MRI. Intestinal ultrasound can be used to assess the disease activities nowadays, and especially in tertiary centers. They can use to assess the thickness of the bowel and can be performed in any prepared bowel patient. As you know, when we send the patient for the colonoscopy or for the MRE, we need to prepare the patient, but with the use of the ultrasound can be done without invasion, without any preparations. DEXA scan might be used to assess the mineral density, especially in patients taking long dose of steroid. And chest X-ray might be done to exclude the presence of TB. This is we comes to the end of my lectures regarding the treatment of the like inflammatory bowel disease. We use certain medication to relieving the symptoms, to healing the mucosa, preventing the next flare, reducing the chance of complications, and improving the quality of life. So this is our target for treatment of patients with inflammatory bowel disease. So we have main lines, which is called like 5-ASA, steroid, immune modulator like azathioprine, MTX, biological agent, which are the new adventures of treatment. We have the main target, the main lines is the infliximab, which is called Remicade, adalimumab, Humira, vedolizumab, Entyvio, and ustekinumab, which is the Sterala. Sometimes we use antibiotics like metronidazole and ciprofloxacin, especially after post-operative Crohn's disease. And sometimes we use, especially in pediatric age group, exclusive enteral nutrition. The last slide that I need you to know about the inflammatory bowel disease. You need to know that there are certain common symptoms that happen in inflammatory bowel disease and the IBS, because many mistakes happening by even specialists when they encounter any patient with certain abdominal symptoms, like they regarded this as a patient falsely as IBS, and on the contrary, they diagnosed the patient with the IBS with the inflammatory bowel disease. So here there is certain symptoms common in between IBD and IBS, like abdominal pain, urgency, diarrhea, change in constipation, alternating bowel. So, so this is a common symptoms happening in both IBD and IBS. But when you see these symptoms and signs, so you need to think about inflammatory bowel disease more than the IBS. So when there is weight loss, elevated biochemical markers, nocturnal symptoms, patients with inflammatory bowel disease, they have usually the nocturnal symptom, while IBS never ever awake the patient at night. Blood in stool, fever, obstructive symptom, anemia, iron deficiency, low albumin. All these mean there is a prolonged inflammation. So when you keep in mind these symptoms, so you can encounter or diagnose patients with inflammatory bowel disease, and you don't falsely get to diagnosis of IBS in patients with inflammatory bowel disease. Okay, we come to the end of my lecture. I hope you enjoy this lectures about inflammatory bowel disease. Thank you very much for your listening. I am happy to receive any question later on if you need any help. Thank you very much.